Welcome to This Week in Orthopedics. This week we're covering 10 notable papers spanning shoulder arthroplasty and rotator cuff surgery, joint preservation around the knee and hip, and a cluster of spine papers on classification, biomarkers, and operating on older patients. Let's dive in. We'll start at the shoulder, where a registry study, a meta-analysis, and a randomized trial each push in a slightly different direction. In the Journal of Shoulder and Elbow Surgery, Nguyen and colleagues interrogated more than 63,000 primary stemmed, reverse total shoulder replacements from the Australian Orthopaedic Association National Joint Replacement Registry, asking whether the degree of polyethylene cross-linking matters for revision. Stratified by the three commonest diagnoses, the answer was that it does, but selectively. For osteoarthritis, non-cross-linked glenospheres carried roughly triple the revision risk from about 18 months onward compared with highly cross-linked components, with no such signal in rotator cuff arthropathy or fracture. Non-cross-linked humeral cups in osteoarthritis showed about a 30% higher revision rate, and after fuller adjustment for the post-2015 cohort, including body mass index, glenosphere size, and image-derived instrumentation, that penalty rose to roughly 80% higher in osteoarthritis and about 50% higher in cuff arthropathy. The detail worth carrying into clinic is that the commonest reason for revision in the non-cross-linked osteoarthritis group was infection, which is biologically curious and reminds us that all-cause revision in a registry is not the same as wear failure. The glenosphere signal was substantially confounded by patient and implant covariates. The humeral cup signal held up better. Staying at the shoulder, Arthroscopy published a systematic review and meta-analysis by Seok and colleagues pooling 18 randomized controlled trials and just over 1,300 patients comparing single-row with double-row arthroscopic rotator cuff repair. Across all comers, double-row repair reduced retears. Overall retear was close to twice as likely after single-row repair, and partial thickness retear nearly 3 times as likely, with modest advantages in the University of California, Los Angeles score and forward flexion at the cost of meaningfully longer operating time. The clinically useful part is the subgroup split at 30 mm. For tears larger than 30 mm, double-row repair was consistently better on both function and structural healing. For tears under 30 mm, the two techniques were indistinguishable on every outcome. So the practical message is to reserve the extra anchors, the extra time, and the extra cost for the large tears, and to feel comfortable with an efficient single-row construct for small and medium tears. Alongside that, a Level 1 prospective randomized trial in the Journal of Shoulder and Elbow Surgery from Sarikas and colleagues addressed a question most of us settle by habit: which immobilization device to use when treating a proximal humeral fracture non-operatively. They randomized just over 100 patients to a Velpo bandage, a standard shoulder arm sling, or a padded shoulder arm sling, and found no differences at all. Not in the subjective shoulder value, pain scores, the American Shoulder and Elbow Surgeon score, the disabilities of the arm, shoulder and hand score, the constant score, or range of motion. Non-union occurred in about 4% of patients and malunion in roughly a fifth, with malunion rates comparable across groups. That is a genuinely negative trial in the most useful sense. Choose the device your patient finds most comfortable and your department can most cheaply supply. Our second theme is joint preservation, the knee and the hip, and here two papers offer encouragement while two temper enthusiasm. In knee surgery, sports traumatology, arthroscopy, Hennessy and colleagues used 25 years of hospital episode statistics data from England to describe the short-term safety profile of nearly 25,000 osteotomies around the knee. Mostly high tibial osteotomies. 4 is not this one. See reference list. In a population averaging 41 years of age and largely free of comorbidity, about 2% of patients underwent a reoperation within 90 days and about 7% within a year, with infection accounting for roughly 2% of patients at 1 year. Conversion to arthroplasty within the first year was well under 1%. Serious medical complications within 90 days affected about 2% of patients, with pulmonary embolism in roughly 4 per 1,000, and myocardial infarction and stroke each in about 3 per 10,000. Comorbidity burden, not the procedure itself, was the strongest predictor of trouble. Useful concrete numbers for a consent conversation. Complementing that, Arthroscopy published a meta-analysis by Shang and colleagues of 10 randomized trials and 460 patients with osteonecrosis of the femoral head, comparing core decompression alone with core decompression plus bone marrow-derived cell therapy. The combination improved pain and hip function, and roughly halved the risk of losing the hip joint, with no excess adverse events. The important caveat, which the authors state plainly, is that radiographic progression did not differ between groups, and the evidence base is small and heterogeneous. So this is a signal worth acting on cautiously rather than a settled standard. On the more skeptical side, Vasiliadis and colleagues in knee surgery, sports traumatology arthroscopy, pooled 6 comparative studies, only one of them randomized, covering just over 300 patients to ask whether adding a centralization procedure to medial meniscus posterior root repair actually controls meniscal extrusion. It did not, in any convincing way. Post-operative extrusion was numerically low in the centralization group, but the absolute difference was about 0.5 millimeter, while inside measurement noise and heterogeneity across studies was high. LISHM, International Knee Documentation Committee, and pain scores were all indistinguishable. For now, centralization should be regarded as unproven rather than routine. And in a sobering small series in arthroscopy, Akrivos and colleagues followed patients who developed postoperative infection after anterior cruciate ligament reconstruction out to a mean of 16 years. All 7 infected knees had radiographic 3-compartment osteoarthritis, compared with about a third of matched uncomplicated controls. Alignment, laxity, and clinical scores did not differ, which is both reassuring for function and a warning that the radiographic damage accrues silently. 7 patients is a very small number, but the direction is unambiguous, and the message for infection prophylaxis and aggressive early management is clear. Our third theme is spine, where this week's papers are about decision-making rather than technique. Spine published a global survey by Vaccaro and colleagues of 159 spine surgeons and neurosurgeons, using clinical vignettes built on the AO spine upper cervical injury classification to derive an operative threshold score. Pattern scoring 3 or below were managed non-operatively with consistency, pattern scoring 5 or above were treated operatively, and a score of 4 sat in a genuine equipoise zone with no consensus. High severity morphology, unstable B2 subtypes, and any significant neurological impairment crossed the operative threshold. This is expert opinion rather than outcome data, but it gives a shared vocabulary for upper cervical trauma discussions. Also in spine, Lavecchio and colleagues prospectively measured bone turnover markers before and 6 weeks after anterior cervical discectomy and fusion in 33 analyzable patients, of whom about 30% had radiographic pseudarthrosis at 1 year. Baseline demographics and surgical factors did not separate the groups, but the early rise in procollagen type 1, N-propeptide, was significantly greater in patients who went on to fail to fuse, and it remained an independent predictor in regression. Bone resorption measured by C-telopeptide did not differ. With 25 of 58 enrolled patients missing their 6-week labs, this is hypothesis generating, but it raises the possibility of identifying non-union risk at 6 weeks and testing anabolic agents in that window. Finally, Hardaker and colleagues in spine propensity matched 83 patients aged 70 or older against 83 younger patients undergoing short segment anteroposterior lumbar fusion for degenerative disease. Surgical time, blood loss, length of stay, and complication rates in hospital and at 30 days, 90 days, and 1 year were all similar. The one real difference was discharge destination. About a third of the older patients went somewhere other than home versus 1 in 10 of the younger group. Age alone should not exclude a patient from circumferential fusion, but discharge planning should start before the incision. If you only have time for one paper this week, make it the arthroscopy meta-analysis of single-row versus double-row rotator cuff repair. It draws a clean, size-based line through a technique debate that has run for 2 decades, and it will change what you plan for the next small tier on your list. Here are the key takeaways from this week in orthopedics. Reserve double-row rotator cuff repair for tiers over 30 mm. For smaller tiers, single-row is equivalent and faster. For conservatively managed proximal humeral fractures, the immobilization device does not affect outcome, so choose on comfort and cost. In reverse shoulder arthroplasty for osteoarthritis, non-cross-linked polyethylene components were associated with higher all-cause revision, with infection prominent among the reasons. Osteotomy around the knee is safe in young, healthy patients, with about 2% 90-day reoperation and 2% 90-day medical complications, and comorbidity is the dominant risk driver. Adding centralization to medial meniscus root repair has not been shown to reduce extrusion meaningfully. And in the spine, age alone is not a contraindication to circumferential lumbar fusion, though non-home discharge is 3 times more likely in patients over 70. That's your roundup for this week in orthopedics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And think of one colleague in any specialty who never has time to keep up with the literature. Tell them about Audio Scholar, a free 10-minute weekly for every specialty, to listen to in any podcast app or to read at audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.